Thank you all for coming out. I certainly want to extend a warm welcome. It's last lecture, end of the day. I want to definitely thank Sarasota Memorial Hospital for the kind invitation to hear Dr. Patrick Layden last night speak. He gave a wonderful scientific presentation on the benefits of hypothermia. And so when Mauricio asked me to present on stroke and pregnancy, I thought I'd start off by giving you a little bit of more of a sense of what we oftentimes have to deal with individually, that stroke has emotional impacts. I thought I'd introduce you to a little fellow by the name of baby Ivor Benson. This is taken from his dad's e-journal. He starts off by telling us that unfortunately his wife is dying. They are both 32, and that she is 22 weeks pregnant. Yesterday morning, she was complaining of a headache, and she asked to go to the store to get some Tylenol for her. When he came back, he found her unconscious in the bathroom floor, so he immediately called 911. The ambulance came. They tried to get his wife to be resuscitated, to respond. They worked on her diligently for an hour, so they transferred her to the hospital. And there, unfortunately, they discovered that she had a random type of, as he puts it, blood leak into the center of the brain, and that there was so much blood and damage that it was not going to be reversible. She was declared brain dead. This brings dilemmas, because here we have a young couple just starting out, and now adding to their family when tragedy strikes, stroke and pregnancy. What do you do? So let's do some updates. Here he writes later on, some 8 weeks afterward, that is with a heavy heart, but also with extreme proudness, that he's posting this update. On Saturday evening, my beautiful and amazing son, Ivor Cohen Benson, was born. He's healthy, the cutest and most gorgeous person that he's ever met. This is as to be expected. It will be a bumpy ride for Ivor and Mr. Benson as he continues to grow under the care of the staff in the hospital. Unfortunately, he posts on Sunday that he had to unfortunately say goodbye to the strongest and most wonderful person he'd ever met. He's going to miss Robin, his wife, more than words can express. And he would know that he was very impressed by her strength, that he was lucky to be with her, and that she would live on in his heart, in Ivor's heart, on and on. So we'll wipe away our tears and appreciate the consequences of stroke and pregnancy. Fortuitously, not all that uncommon, but at the same token, it's concern in that there is some likelihood of increases. The incidence of stroke during pregnancy will range anywhere from 9 to 34 per 100,000 deliveries worldwide. Recognize that of all stroke types, intracerebral hemorrhage during pregnancy carries the highest morbidity and mortality, with an in-hospital mortality approaching 20%. The good news in that the morbidity following pregnancy related to strokes typically is less than for typical stroke patients, the older adults, and the risk for recurrent stroke subsequent pregnancies is actually very low. We know that during pregnancy, for instance, in the United Kingdom, 11 to 26 deliveries per 100,000 are documented. Approximately 8 to 15% of pregnancy-related stroke victims, again, will die. C-section deliveries, they carry a 3 to 12 times greater risk than vaginal deliveries. A study in the United Kingdom identified that thromboembolism, blood clots, was the leading cause of maternal death. Here in the United States, of 5,723 cases were attributed to thromboembolism. This is death in 8,900 women. Most common cause of cerebral infarction correlates with eclampsia and preeclampsia. And most common cause of intracerebral bleed, it will be associated with arterial aneurysms and AVMs. We know that stroke here in this country accounts for 3.5 to 26 cases of neurologic dysfunction per 100,000 deliveries, and it is associated with a maternal death of 12%. The good news here, as is seen worldwide, is that before we would tell you that stroke was the third leading cause of death. Now we're down to 5. But again, the incidence of stroke during the childbearing age alone is 10.7 cases per 100,000 women, and perhaps rising. It begs the question, is pregnancy unto itself a risk for having a stroke? So when we want to consider stroke in pregnancy, we will recognize that we can categorize this into 2 boxes, if you would. One being stroke directly attributable to pregnancy and its complications. The other, we will see stroke in young adults. Recognize that preeclampsia will be present in anywhere from 24 to 47% of stroke and 14 to 44% of intracerebral hemorrhage. Choriocarcinoma, a rare germinal cell tumor, oftentimes occurs early on in pregnancy, usually associated with atypical pregnancies, molar pregnancies, ectopic pregnancies, rather rare, but potentially lethal tumor associated with stroke, and these tend to metastasize to the brain, and they tend to be very vascular, very likely to bleed. We know of amniotic fluid embolisms, in which there's disruption between the maternal fetal barriers. Some fetal cells get into the maternal circulation, go up into the lungs, and perhaps cause a type of acute respiratory disturbance, fatal in up to 80% of cases. Then there are more rare conditions, things such as postpartum cerebral angiopathy, fortuitously reversible condition that can be associated with ischemia, hemorrhage, and death unto self. So then we have to recognize that stroke can occur in young adults. It is associated with atherothrombotic events. It's associated with cardioembolic events, lacunar infarcts, and the disease that are associated with this. We see this with vasculopathies, such as fibromuscular dysplasia, dissection, history of radiations to the neck for thyroid tumors or the like. There are certain hematologic disorders that will predispose to stroke, including factor V deficiencies, any hypercoagulable state. Drugs, certainly, unfortunately, rising in use, things such as cocaine, vasoactive substances, methamphetamines, even chronic use of phenylephrine. It reminds us as neurologists to be careful when we prescribe certain allergic agents. We want to try not to avoid, or we want our patients to avoid not overusing our triptans. We can see this as a direct consequence of migraine to itself. And certainly there are further causes to be found. So why is it that pregnancy could potentially predispose to a stroke? Well, the thing that you will take away from this is that pregnancy is associated with a hypercoagulable state, particularly as the pregnancy progresses. And remember that this is where we're going to more than likely see the manifestations of stroke later on into the second, third trimester. We know that with pregnancy, there will be a marked increase in fibrinogen and factor VIII levels. There are also lesser increases in factors 7, 9, 10, 12. And we know that there is a reduction in the fibrinolytic activity during pregnancy. As such, deep vein thrombosis is a very common complication of pregnancy. Anywhere from 1 to 2% of vaginal deliveries and 2 to 10% of C-sections will be associated with the development of DVT. And from DVT, we go on to manifestations of cerebrovenous thrombosis. Here, this can present as either severe refractory headaches, which in turn go on to develop stroke, seizure, even bleeding. Again, it's because of this hypercoagulable state during pregnancy that the CBT is much more common than any other time that you will see. And it is also known that during that postpartum period, right after delivery, up to 6 weeks afterwards, this is where you'll have the highest risk of the development of a cerebral venous thrombosis. In fact, in one study, the risk of developing an intracranial venous thrombosis was 11 per 100,000 deliveries. And here you can see in our arrow the blood clot. So then we also know that associated with stroke and pregnancy is the development of hemorrhage. Women are at greatest risk for intracerebral hemorrhage, again, with eclampsia, with the vasculitis, with aneurysms, vascular malformations. Above all else, it's that high blood pressure that's the most important risk factor for the development of intracranial hemorrhage in pregnancy. So much so that oftentimes one is asked, when we have women who are known to have AVMs, aneurysms or the like, in the past we would say perhaps it's not a wise idea to have pregnancies, to give birth to children. Came across in the topic a study that was recently published last year out of Tianjin in China, in which they looked at 979 women who had intracranial AVMs, and these were followed over the course of a lifetime, from 1960 to 2010. They found in these 979 women, 797 had hemorrhage that occurred over the course of some 25,000 patient years. They found that the annual AVM hemorrhage rate in patients from the age of 18 to 40, some 579, was about 2.78%. And this is actually lower than the elder age groups, a thing that one would anticipate. Of the 393 patients who had rupture, again, of the AVM from the time of 18 to 40, 12 hemorrhages occurred during, for 12 patients during their pregnancies, of 452. And the take-home message from this study is that the odds ratio of a rupture of an AVM during pregnancy, during the pregnant state, postpartum, compared to controls, was actually less, 0.71. And so in the past, one would think perhaps if a patient were to come to us and is pregnant, we know that she has an AVM, one would say perhaps we should immediately treat it, surgically get rid of it. But perhaps this gives us food for thought to say perhaps not. Maybe we need to, as Aruba tells us, be a little bit more medically conservative. I'd wanted to introduce to you a concept of postpartum cerebral angiopathy. Best done through a case. Here we present a lady, 30 years of age, who presents with severe headache. There's associated nausea. She's throwing up. She's going to the hospital. She's in severe distress. She reports a spontaneous, sudden onset of headache with nausea and vomiting that started some 3 days ago. They would come almost right on top of her. She described the headache as a generalized pressure that would develop with maximal intensity within a minute. It would be associated with nausea, with vomiting, but no other symptoms. The patient had delivered her second child some 6 weeks prior to the development of these headaches. No complications were encountered. And she would tell us that the first pregnancy and delivery went uneventfully. They were normal. So when she was seen in the emergency room, she was afebrile. Blood pressure was 110/80. She was in sinus rhythm at a pulse of 90. She was awake, a little bit fully oriented, but again, complaining of pain. The remainder of her examination appeared normal. She would be admitted to the hospital, and over the course of the hospital stay would go an extensive workup, including a negative hypercoagulable state. Again, because of severe sudden onset of headache, coming back from the neck and radiating up, she did get a spinal tap, and that showed no increase in cells, normal protein, normal glucose, no xanthochromia, things that you would anticipate if you were dealing with subarachnoid hemorrhage. She would go on during the course of her stay to complain of further paroxysms of severe, rapid onset headaches. They were associated with photophobia, phonophobia, so much so that more consultation was requested. She was found on follow-up examination to have difficulty in concentrating. She seemed agitated. Speech was normal. Comprehension was not disturbed. She was in severe distress due to the pain. She was fully alert, oriented, and somewhat in a panic. Her cranial nerves appeared intact. Bilateral brisk symmetric deep tendon reflexes. There was no clonus. Ocular signs, again, showed perhaps a little bit of nystagmus. She was perhaps ataxic, but this was thought to be because of the amount of pain that she was in. Everything else appeared normal. So she was treated again empirically, analgesics. They're thinking maybe this is an infection from presenting with the nausea. So she was followed in the hospital. On the third night, she became comatose. And now she developed left-sided focal neurologic symptoms. Repeat CAT scan was performed. Here the radiologist diagnosed an intracerebral hemorrhage on the scan, and the suspicion was that maybe she had a venous angioma to the right occipital lobe, and that this was enlarging. So they sent her down for angiogram, and this was not confirmed. But what they did find is revealing. Above all else, you have to know the case. You have to know your patients. You cannot rely just on what the radiologist will tell you. And this is where, time and again, our experience shows that we want to look at our imaging studies, we want to look at our patient and correlate. Because this is the first scan, initially read as relatively normal, perhaps 2, 3 in the morning. Radiologist takes a quick look at it and says, I don't see any bleed, nothing bad. He's told this is a patient who's having a stroke, perhaps, and he says, don't see a stroke, don't see mass effect, don't see midline shift, the standard read. But yet, on closer inspection, you do see things of concern. You see, for instance, in the third and lateral ventricle, here in the blue, that there's perhaps an increased intracranial pressure. We see further on the right occipital region, hemorrhagic infusions in the right parietal occipital lobe. And you can see this clouding here. So that when you look at it in contrast, again, you see the hemorrhage becoming a little bit more appreciable. This would indicate that perhaps here we're seeing breakdowns in the blood-brain barrier. So when we look at the CAT scan that was done on that third day, clearly we see areas of hemorrhage of varying degrees in size. And we also start to be concerned because there is the development of early hydrocephalus. We can see the displacement of the midline structures that's accounting for perhaps the coma. So when we do look at the CT angiogram to see if this is an AVM, what we see is actually quite revealing, quite interesting. And then you can appreciate these little sausages, if you would, throughout all the arterial systems. Here in the arrows, notice how they come about as though they're being squeezed. And this is very classic for the postpartum cerebral angiopathy, a type of reversible cerebral vasoconstrictive syndrome. It's going to peak over the course of 1 to 6 weeks postpartum period. We're going to see the affected blood vessels occasionally showing signs of inflammation on histologic investigation. The early CAT scans may see some blurring, particularly on the border zones, on the watershed regions. We will see inflammatory changes, mainly of chronic secondary to prolonged vasoconstriction. So all these patients who are coming to you and telling you have got very rapid onset headaches that occur very rapidly, severe, within minutes, keep this in mind. Because when you have multiple thunderclap headaches, this is almost pathognomic for this condition and for other reversible cerebral vasoconstrictive syndromes. In laboratory findings with this condition, you will see an increase in the erythrocyte sedimentation rate. You'll see a leukocytosis. Most of these findings will reflect what is thought to be release of inflammatory cytokines. There may be a component here where serotonergic input to the blood vessels is also increased to account for the vasospasm. We see on CT and magnetic resonance scans, they will initially appear oftentimes normal. But with later follow-up, you will start to see ischemia, hemorrhage, edema, or all three. The CSF is usually normal. Transcranial Dopplers, very useful tool, will show high flow velocities, again suggestive of that vasospasm. and the angiogram will reveal areas of stenosis, dilatation, and the classic sausage-like lesion. So what do we do when our patients come to us and we need to treat them? We understand that, again, the focus here is controlling the blood pressure, preventing the clots from forming. And we can divide our categories of medications into anticoagulants and the antiplatelets, the standard stuff. Their safety profile, though, has to be considered when you're dealing with a pregnant individual. We know that aspirin is considered category D, but at low dosages it probably might be safe. Plavix, clopidogrel, category B, again because there's not enough data out there. Dipyridamole, the same thing, but recognizing that the combination of the Aggrenox, be it with the aspirin, again is considered category D. Heparinoids, heparin, are considered standard choice here. They're category C. And remember that warfarin, past the first 6 weeks, has to be avoided. It's associated with problems. So let's expand. Aspirin for the prevention of stroke in pregnancy. It can result in fetal complications, particularly if given over prolonged periods of time at high dosages. During the 3rd trimester of pregnancy, the aspirin may lead to closure of the fetal ductus arteriosus. It can, in pregnancy, predispose to maternal and fetal hemostasis. We can see with high dosages an increase in perinatal mortality, intrauterine growth retardation, and there are teratogenic effects that are reported with high-dose aspirin. Having said that, though, women who are at high risk for preeclampsia, according to the American Academy of Family Practitioners and the American Obstetrics Association, will tell us that low-dose aspirin, 81 milligrams, after 12 weeks of pregnancy to prevent the condition and its related health problems is probably the way to go. So when we look at the use of warfarin, we know that it will cross the placenta. It can cause complications with organogenesis, particularly during that 6 to 12 week post period afterward. We know that maternal fetal bleeding can occur with warfarin, and this can occur spontaneously, resulting in spontaneous abortions and stillbirths. With regard to the newer oral agents, direct-acting thrombin inhibitors, factor Xa inhibitors, we still don't know yet. The data is not out there, and as such, these are medications perhaps to avoid. So what do we do when we see a patient who has venous thrombosis? Here again, low molecular weight heparinoids are recommended as opposed to unfractionated heparinoids because of ease of control. The continued treatment is recommended for at least 6 weeks postpartum. Recommended durations of minimum of 3 months. And then discontinuation of the heparinoids perhaps a little bit more than 24 hours prior to the induction of labor or a C-section. Alteplase. One would think, how could we possibly use this agent? But yet pregnancy, and in fact, when you look at the registry data, you look at the recommendations, perhaps even your little stroke trackers, you'll see that it is considered relative exclusion. However, remember that alteplase, TPA, is a large molecule, over 7,000 kilodaltons, and as such, it will not cross the placental barrier. Because of that, there's no teratogenic effects that have been documented in animals, no tumorigenicity in rodents, no mutagenicity or production of chromosomal abnormalities have ever been shown. And in rabbit studies, there's been no maternal or fetal toxicity at dosages what we would typically use. What benefit could we see in pregnancy? Well, there are currently 8 mothers who were treated with good neurologic recovery. Most of the mothers would go on and do well. One patient had an intraarterial angioplasty. This led to dissection. Another with a malignant MCA infarct, unfortunately, who went on to die. One patient sustained an intrauterine hematoma that was drained. Fetal outcomes in 5 babies were very good. In 2 early cases, medical termination of the pregnancy was opted for, and 1 child died with the mother. As such, when you're called into the L&D suite or at any point in time when you're dealing with a woman who is pregnant, perhaps it's best to rethink the exclusionary criteria and say, well, I can't do anything for you, sorry. Because again, lives are at stake. This is probably going to be the most important slide of today's talks. The reason why is because this is where really the money is. It's in prevention of stroke and pregnancy. These are the American Heart Association Simple Sevens. You heard earlier Dr. Ruffing expound on the virtues of exercise. We need to be out there telling our patients, in part because of the fact that 75% of stroke patients will come first-time stroke. So the importance of informing to our patients, don't smoke, quit for more than a year. We want to keep a lean body mass under 25 kilograms per meter square, that BMI. A physical activity of 150 minutes, moderate intensity with your target heart rate of at least 60% of maximal, or for 75 minutes with vigorous exercise, target heart rates of 80% each week. We want to have a good, healthy diet, again, consistent with a Mediterranean-style diet, fruits and vegetables, 4 to 5 cups a day, an increase in the amount of nuts, legumes. We want to keep our total cholesterol down, under 200 milligrams. Our blood pressure, again, mirroring what we see with women with eclampsia, of 120, 80, or below. We want to keep our fasting blood sugars under 100. And I add the last one, the importance of prenatal care, because this is where you're going to recognize the preeclampsias. This is where frequent monitoring of the patients and their baby can lead to prevention of stroke. So again, in patients with known cerebral aneurysms, perhaps some controversies, clipping or coiling may or may not be performed. We don't know, more data. Consider C-section deliveries in patients with known AVM. Opinions differ with regard to the best approach to treating pregnant women with hypercoagulable states. I would tend to favor more toward heparinization. Patients who previously took warfarin because of recurrent venous strokes should be counseled of the need to switch them over because of the impact of the Coumadin, the warfarin, on teratogenesis. Some authors will recommend now more and more low-dose aspirin for women who are at high risk for the development of thromboembolism, for preeclampsia. And again, above all else, decisions regarding the treatment of mild to moderate thrombophilias need to be individualized. You have to take a look at the whole patient in a nutshell. So with that, we leave you with time for questions, but I want to update you on baby Ivor. 4 months after first entering the hospital in February, he and his father went home. It had been a very long journey. The days are still very tough, especially after Mother's Day. Think of last weekend. But having him home is a wonderful experience. He left the hospital May 5th of 2014. At that time, he was 8 pounds, 6 ounces, and 21 inches tall. So with that, again, thank you so much. And we open up the floor for questions.